Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast. We have another guest today. His name is Dr. Mark Holthouse. He's an MD, but practices functional medicine in his clinic, and he is a specialist in hormone optimization. We're going to ask him what that actually means. And he helps people from a functional medicine standpoint improve their aging process. So, Dr. Mark, welcome to the Thyroid Answers podcast. How are you today?
Doing well. Honored to be here. Yeah, that's exciting.
So it's interesting, MD coming to the world of functional medicine, and some people might say, like, what brought you here, right? What's the story of how you got to functional medicine? Maybe that's the best place to start.
That's easy. Family practice for about 15 years, and in 2006 had an existential crisis of sorts where I just felt like a glorified drug rep. My scope of practice as a family practitioner, in my era, we were before hospitalists. We used to do our own Swan-Ganz, central lines, paracentesis, thoracentesis at the bedside. We did our own A-lines too, just in-office clinical. And it was less rewarding than I anticipated. And it certainly wasn't proactive or preventive. It was more looking for cancers and screening for cancers as a secretarial administrative position. So I was ready to leave medicine in 2006, and I went down to Scripps in La Jolla and took the American Board of Integrative Holistic Medicine's course, five days foundational, took their board exam, quickly got into IFM, started teaching, got on their faculty. I've been teaching there for 10 years and just started grabbing everything I could learn about mind-body medicine, nutritional medicine, cardiovascular, cardiometabolic medicine, and ultimately hormones. And the beauty of that is that the hormone medicine and cardiometabolic medicine have really converged. It's this Venn diagram where I like to be, the sweet spot right in the center, because they all affect each other. So yeah, I just about left medicine in 2006, and I'm really glad I did, because the last 15 to 17 years has just been an absolute hoot.
I think that's part of the issue, or the huge difference between allopathic medicine and what functional medicine is supposed to be, which is everything we do is in this Venn diagram, right? In allopathic training, and even to some degree in functional medicine training, somebody's a specialist in different categories, but they're missing how all of these things integrate. And that's truly what functional medicine is supposed to be about, is addressing how all of these systems interrelate and interconnect versus how all these systems function separately. And I think that model, that separate model, that reductionist model of, hey, I can just focus on a gut, or I can just focus on male hormones, or I can just focus on thyroid numbers, works great in an acute care disease management, maybe, but it doesn't work in this model. And to me, that's the biggest challenge. We've got a couple challenges. One, we have to make sure patients understand that there's a difference between what allopathic medicine does and what functional medicine does. And we need to make sure, at least in my opinion, and you may differ, and I'm going to ask, that we keep the allopathic philosophy allopathic, and we guard the gates in functional medicine and say, hey, that's great. You can come in here, but if you're going to truly say you're practicing functional medicine, it shouldn't be allopathic philosophy with different supplements and drugs. It should still maintain that foundational concept. So give me your thoughts on that.
No, amen. I mean, my biggest gripe with the Wikipedia definition of functional medicine is one of the phrases is that they overutilize and they just order a bunch of unnecessary tests. We also have the reputation of just over supplementing, death by supplements. We call it green pharmacy.
Yeah, I call it greenwashing, but it's the same idea, right?
Making annuity out of our patients to justify the fewer quantity of office visits per day. So the realities are that in an insurance payer system, it's very difficult to make a living without burning out in functional medicine, because they don't honor or value really anything that we do, regardless of length of stay, repeat hospitalizations. They're not looking at any of those things. They don't care. So I'm out of the insurance realm for that reason. That's a whole other discussion. I can't agree more, though, that functionalism has its own pitfalls where you can become reductionistic even within functional medicine model with over testing, over supplementing, as opposed to being a true diagnostician that recognizes patterns. And I think that the longer I've been in this, the more humbled I've become at how all of us as practitioners tend to see the patient that walks in the door through the lens of what we're the most familiar with. My mycotoxin folks are always looking at how they can fit this person into a pigeonhole of being a mycotoxin disease. My adrenal dysfunction patients, same thing. My CDR, my cell danger, my CDR crowd, where is your mitochondria status at the time? And my Lyme crowd, certainly. It's all Lyme, doc. Functional medicine's great, but it's all Lyme. We have these kind of biases that all of us gravitate towards in our areas that we tend to be the most proficient or knowledgeable in. And so I think if we're all honest with each other, the person that sees us most likely is going to be diagnosed and worked up in the area that we've just been at the most recent conference. Those things closest to our heart that we have insight and understanding and a comfort level with is where our bias is. So I think it's important for us to acknowledge that so that we can truly have this Venn diagram overarching ideology where we can say hormones matter. We probably age as they go away. That's my philosophy. It's probably why we age, one of many reasons why we age. But that, yeah, infections and toxins and other things, and certainly genetics do matter.
Yeah, we all look at things through our own ignorance and our own bias, right? And that you can't escape that. And I think that's the big challenge we have to overcome as functional medicine practitioners is we all talk through a lens. We all do, right? We talk through the cell danger physiology, and I talk through the tissue hypothyroid or cellular hypothyroid model in my world, right? But I rarely ever do anything to directly manipulate labs. I'm usually trying to figure out how do we get the person on the least amount of medication, because the vast majority of people I see who are on medication are over medicated. And to help them, that's step one. They're over supplemented, over medicated. Step one is to reduce that load. But when I see the same thing. Like when you go to seminars, everything's mold, everything's adrenal fatigue, everything is SIBO, it's whatever the shiny object is of the seminar circuit. And I get it. When I was new in functional medicine, I went to my APAC seminars and I thought I figured out functional medicine. I came home when you don't know anything, and you probably experience this going from medicine to functional medicine, you do your first 4 or 5 seminars, you're like, gut protocol, detox protocol, AIP diet. I got it. This is easy, right? Yeah. No problem. And then you realize that works for like the healthy, sick people. It doesn't work for anybody who's got a chronic illness. And then all of a sudden you're realizing, man, I don't know anything. You don't know. Right. And the more you learn, the more humble you get. And the more you realize, man, we've been operating from the wrong model, right?
None of us knows anything. And at the end of the day, you're left with your intuition, with the knowledge that you've put inside here. And if you're good at listening to what the people are saying in front of you and actually listening, that's your best prayer, your best hope. I honestly believe that. And I can't agree more that the more you know, the more you realize you don't know. And you'd need 3 or 4 lifetimes to even come close to attaining something like that. And I don't even know if that's enough time. What's the doubling time of medicine now? Knowledge is 18 months or something. It's like any of us that think we can keep up even in one area, we're kidding ourselves. I mean, I just read David Brownstein's book again the other day, and I thought, okay, from a few years ago, I'd read it. And now from my perspectives with different changes and things on thyroid in particular, I realize I'm a different animal than I was just 5 years ago. And people that have gone to my lectures and said, well, that's not what I learned when I went to your lecture in 2016. I said, oh man, 16, I was saying stuff that I totally disagree with now. And even 2 years ago. And I said, if there's any lecturer that is in the primary journals that's trying to keep up with an evolving hot topic, who's not changing their opinion periodically based on the data, I don't waste my time. It's okay. It's okay. Be vulnerable, but speak your truth with current knowledge, and we have to have that tension.
Yeah, and I think it's good to have discussions, to disagree, because we don't all know, and that's how we learn. We test our theory, we get it challenged, and that's all it is. It's hypothesis, it's theory, like it's what we believe based on all of our experience, what we've read, all this knowledge we've pulled in. We work from a certain operating hypothesis, and many times it turns out to be correct, and then sometimes you get challenged and you go, huh. And I think that's what makes somebody who's a good practitioner better, is if they've got a thought process, a theory, a hypothesis, trying to figure out why it's not correct. Like,
Exactly.
okay, this is what I believe, but why would it be wrong? How, and that's what we really want to figure out. And I think, we've got a lot to talk about, but since this is a Thyroid Answers podcast, everything is in play. I have a bone with how we do things allopathically with thyroid physiology. I have maybe a bigger bone with what we're doing in functional medicine and integrative with thyroid physiology. But maybe, I guess, when you're looking at thyroid physiology, there's a couple different camps. And then this way I'm not putting you on the spot, right?
Thanks,
We've got the allopathic camp that says, hey, we only have to worry about a TSH and free T4.
Yes.
And then if those are out of range, we're going to give you TSH to bring you back into, we're going to give you T4 to bring you back into TSH into a range. Whatever that person decides is the range. And they're not looking beyond that. People get upset and bent out of shape. They didn't run my antibodies. They don't know what they're doing. They do. This is what they learned. They learned that I'm not providing thyroid hormone medication until the gland has lost its function. And then I'm going to replace primarily what it makes. And then the assumption is that it all is going to get into the bloodstream. It's going to get free of the transport mechanisms. It's going to easily transport across the cell. And it's ultimately going to get converted to T3 binder receptors, and all life will be good and kumbaya. And anything that happens that seems like hypothyroid, once I normalize TSH or TSH is within reference range, is not a thyroid condition, as long as the TSH is within range. That we know is not working well, right? Because I think one of the most recent surveys I saw, like 75% of the thyroid population is unsatisfied with their work. And we know that even people in our allopathic physicians, researchers are frustrated. Nobody knows what to do. When do we give it? When do we start? Should we do something else? Then there's the integrative model where they say, okay, we're going to run more. We have to run antibodies. Listen, I think all allopathic physicians pretty much know it's a thyroiditis, immune-driven process, unless it's iodine deficiency. And we can have that Brownstein argument later. But and they're saying, but we're also going to run T3, and what we're looking for is T3 low. And if it is, we're going to give T3 to make up for what's not there, because we need to optimize the bloodstream. I don't know that either one of those models is right. I have a totally different opinion, but I think we have to ask the questions. We have to interpret the labs and say, is this a person who's not converting T4 to T3, whether it's the gland or from T4 medication? And is it appropriate to give T3? Or if the cells and tissues didn't want it to begin with, they're actively deactivating it, why would more thyroid hormone into a system be beneficial? And I know you talk about oxidative stress, redox reactions. Sure. My argument is exactly for that redox issue, but tell me where you stand on this model.
Yeah. So yeah, I'm definitely not in group one. I mean, I haven't been there for 20 years. And then going to the last group where, there's providers that I inherit patients from that are on, 400 micrograms of thyroid, and they still feel like crap. And they
Mhm.
come to me saying, what's wrong with me? And their TSH is, zero point 0.00 whatever.
Mhm.
And their free T3 is 6. They're having palpitations, and they're incredibly, they just feel awful. There's that group who have been told labs don't matter, we just treat symptoms. And I've been to lectures, I've been to seminars, we all have, where that's been taught up front. I'm certainly somewhere probably more where I'm evolving in this area, right? As a family practitioner, I've always been afraid of being called out for precipitating AFib or osteopenia, osteoporosis, especially in people over 65, by suppressing their TSH. My personal belief is that if you look at the history of TSH and how it was developed, it was at best a weak predictor of diagnosing hypothyroidism. It was never meant to be used to monitor dosing. And so I don't use it that way anymore, but I still, as a licensed family practitioner, board certified and state licensed, I'm also aware that there are plenty of cardiologists and ER physicians who, when somebody has an AFib event and draws thyroid labs in the ER and looks up who is the primary care physician writing this medication, then I'm vulnerable to be, called on the carpet by my own board. And I know friends that have been in big trouble for doing that and been reprimanded for over suppression of TSH. So my view is one that is, I don't know which camp it's in. It maybe is closer to the second group, but it's really a personalized approach, right? And I'm trying to incorporate what I know about reverse T3, what I know about total T3 to reverse 3 ratios, what I know about T1, 2, 3, and 4, what I know about resistance at cell level, with cofactors and minerals, with symptoms, constipation, ongoing cold intolerance, and this new cell molecular medicine that is taking integrative medicine by storm right now. And this is really the crux of peptides. William Seeds and some of these other guys that have become experts in these areas, they come back to cell signaling and redox, CDR, mitochondria at the center of all of this, with pro-growth and mTOR and autophagy and catabolism with AMP kinase, and finding this balance. So I'm moving from just looking at labs and symptoms with thyroid to trying to see on a bigger scale, bigger stage, if you will, how does promoting healthy cellular redox status, electron transport train, and Krebs cycle, ATP, mitochondrial uncoupling, endoplasmic reticular stress, leptin, cardiometabolic diseases that are signaling via catecholamines, neurotransmitters, insulin, counter-regulatory hormones such as glucagon and cortisol to the thyroid. And then, yes, we don't use the term adrenal fatigue anymore. There's no cortisol steal. I mean, we understand the concepts behind that, but those have caused more grief than anything else. So we call it adrenal hypofunction. And we know that the adrenal levels, the functional cortisol and ACH levels, have an intimate connection with thyroid, as does estrogen and some of the other sex steroids. So I think it's difficult because it isn't easy for us to just look at a few lab parameters of, just to look at zinc and selenium and just to think we have an idea with reverse T3 that we're going to figure that all out is really arrogant. I I think it's much more complex than we ever understood, and I think it's happening in a cell molecular basis. Um, and so redox is becoming increasingly more important and insightful to me as a micro to the macro problem, if you will. I don't know if that makes any sense, but this is where my mind's gone.
Yeah, I think that's the direction you have to go. And we have to look at what's happening at the cell. My opinion is we need to spend more time thinking about what's happening in the cell. I think one of the things that we assume is that what's happening at the cell is always broken. And I think that's a mistake. I think we have to start to consider that what's happening at the cell may be adaptive change, at least at the onset, part of cell defense. And now, is that good or bad? Does that make us feel good or bad? Many times it's good initially, but when we get stuck in that state, it becomes problematic. So you introduce this term redox, cellular redox. Some of the listeners know what that means, some don't, but let's take some time. What do you mean when you talk about cellular redox? Explain what that is.
Yeah. So I'm looking at NAD, I'm looking at NADH, NADPH, the ratios of these vitamin B3 derived cofactors that are used in the Krebs cycle in the mitochondria. And these are things that give us an idea of the oxidative versus the reductive capacities of the cell. And we know that the mitochondria is where most oxidative stress is occurring within the cellular environment. So this is where you've got mitochondrial DNA, which lacks the ability to repair itself, as does nuclear DNA, developing errors and creating terminal events, which leads ultimately to apoptosis, or in some cases to a state of stasis or zombie cells, which then become bags of bad influence and cytokine storm and inflammation and inflammasome activation. So the mitochondria is truly at the hub of this discussion, whether you're talking sex steroid hormones, whether you're talking about oxidative reduction capacities of the cell. And largely the mitochondrial health is what's telling the rest of the cell to check itself out, off itself or not. And so this is where I think you have this convergence of cellular inflammation, NRF2 and antioxidative response elements, NF-kappa B, inflammasome, with things such as the production of these macro hormones, whether they're cholesterol-based or protein-based peptide hormones.
So let me kind of simplify that for maybe the listeners. When we think about the cell, and you can correct me if you want to change this, but a cell kind of operates in one of two modes. It's either in manufacturing mode,
yep,
or it's in cell defense mode. Those are the two primary modes that kind of cells going back and forth in. And for the most part, when cells are healthy and they're in manufacturing mode, they're trying to bring glucose in, thyroid hormone in, they're trying to bring amino acids in, and the whole goal is to build stuff. And we need energy to build all this stuff. And inside the cells, we have these engines we call the mitochondria. And essentially, we put food, glucose, and maybe some fats. We can put things, fuel, essentially, food fuel into this mitochondria. And we can turn that into cellular energy we call ATP. And then we can use that ATP to do all these cool reactions in the body. We make muscles bigger, stronger, move, relax. We can make hormones. We can make protein, amino acids into peptides, peptides into amino acids. We can make hormones. We can do all this cool stuff. Downside to that process is there's some exhaust. And we call that like free radicals, right? There's some exhaust that's essentially generated. And when we talk about redox, we're creating this oxidative free radicals, this exhaust. And we need to make so that exhaust doesn't create damage or destruction or death of a cell. We have to produce these things that are going to reduce that exhaust back to something that's safe and not going to destroy the tissue. And we have antioxidants and anti-inflammatory processes that go on in the body. And he was mentioning NRF2. NRF2 is like our major master anti-inflammatory, antioxidant, detoxifying gene. It turns on like 200 processes that help detox inflammation and oxidative stress. It is like the thing. It's one of the things I talk and lecture about. I love the idea of NRF2. Little side note, people, broccoli, the sulforaphane from broccoli sprouts, 3 to 5 day old broccoli sprouts, is like one of the most potent upregulators of the NRF2 system. Really potent upregulator. Anyway, so that's what's going on in the cell, right? And thyroid hormone is critical to driving that process because you need T3 to help drive this whole mitochondrial system. And we need to make, it sounds weird, but to make that mitochondria less efficient, we need T3 to really drive that process. When you're hypothyroid, we have fewer mitochondria. They're more efficient at turning food energy into cellular energy, but there's a downside to that because we lose this ability to dissipate some of that energy as heat. So thyroid hormone plays a role. So keeping that in mind, that we have to have this balance between what's going on there. And we know, or we believe, I should say, that inflammation, oxidative stress is a huge driver in what's causing us to have illness, or aging, disease. What do you see as the big drivers of what's creating chronic illness? I mean, 50% of the US, I think it's 40 to 50% of the US adult population's on a statin. We've got 50 to 70% of the US population's either overweight or obese. We've got a massive amount of people who are on antidepressants and anti-anxiety medications and pain medications. So what do you see as driving the stress response? Because a lot of people would say, oh, it's mitochondrial dysfunction. And I'm like, well, maybe it's not dysfunction. Maybe it's an adaptive change. Yeah. But what do you see as really driving the cellular compromise that's going on?
Yeah. I think it's all of those things. I think that it's environmental, and I think it's heavy metals. We know that heavy metals can poison these antioxidative systems and these enzymes that buffet us against reactive nitrogen and reactive oxygen species inside the cell, specifically. And then it's certainly organic solvents. It's organophosphates, it's organochloride pesticides, it's herbicides. It's the atrazine that they're putting on our corn as an herbicide. That's related to breast cancers. It's the glyphosate, which is opening up the zonulin and leaky gut. And then, God forbid, you get gluten coming through, and now you've got translocation of lipopolysaccharides from your bacteria, and off we are to systemic inflammation land across the body. So I think it's largely our food and our environmental toxins. Our genes haven't changed. Why am I've been doing family medicine for 35 years. We used to see a case of Hashimoto's, a new case, once every 6 months. I see a new case of Hashimoto's almost daily diagnosing in my practice. And I always tell patients, and these are in males, not just in females, where it's much more prevalent. And in young adolescent males, I never saw that 10 years ago. So our genes haven't changed. We know that the thyroid is a sentinel endocrine organ that's extremely sensitive to external environmental toxins. And so it's my opinion that it's our food that's oxidizing us. It's pro-inflammatory. It's measurable, not just with CRP, but with other classes of cytokines, even before the liver can pump out C-reactive protein. So much of the aging that we're seeing now is not just length of telomerase and other DNA enzymes, but it's having to do with the pattern of cytokines that's predominant within our bodies now. Stanford's got a test called the IH test, which is a particular cytokine that's been correlated with fragility and cardiometabolic disease and mortality. So we're getting closer and closer to be able to identify specific intermediaries of aging, and it's usually through the immune system. The immune cells and the immune cell aging process seems to influence the aging of all the other cell types and organs in our bodies. So yeah, the quick answer is I think it's our food. I think it's our toxic relationships. It's our stress, our sedentary lifestyles, it's our smoking. All these things are pro-oxidative, and certainly chemicals. And I believe personally that endocrine disrupting chemicals are largely responsible not only for much of the thyroid dysregulation that you're seeing and that I'm seeing, but also the male infertility, female infertility, certainly PCOS, endometriosis, problems with menstrual irregularities, and decreasing in androgen levels worldwide now, not just in certain countries, but all over the world. And so I think it's happening at a cell level, and I think it's happening in the mitochondria. When this oxidation and this redox balance gets out of whack, we start oxidizing our fats. We start creating lipid peroxides. We start oxidizing our DNA and creating carcinogenic adjuncts in our DNA, which leads ultimately to cancer. And so this is where I've kind of, in this humility of learning over the last 30 years, plus the last half of that being more integrative and having to really get into the biochemistry and being associated with IFM, where I'm hearing multiple specialists from their little areas, their niche in specialty, it really does seem to come down to the cell and molecular provocation and how the cell is having to adapt in a hostile world. And what is heart failure? What is hypertension but an adaptation to the blood vessel and the cardiomyocytes to a perceived threat? And what starts out as a seeming life-saving adaptation ends up being a compromise that leads to dysfunction and ultimately death. So yeah, I think it's the same thing in a cell level.
So for the listeners, I've covered this a lot on the podcast. We have these two operating kind of modes. One's called homeostasis, where essentially we make all the energy we need to do all the stuff we need to do. And we're primarily in that kind of manufacturing mode. And then we have this thing called this allostatic regulatory mode, where there's some type of stress response. We're not generating all the energy we need to, and we need to shut down certain systems that are less important to for survival and deal with the threat. And that threat could be physical, could be chemical, emotional, microbial. It's the load. And I think that's what Dr. Mark's kind of getting to, is like, there isn't a thing. We discuss these things as the thing that fixes your hormone physiology, or the thing that's going to fix your thyroid physiology. This is H. pylori is the cause of Hashimoto's. Like, maybe, but maybe not, right? So what happens when you're in this adaptive regulating mode, you're turning down the energy to a whole bunch of systems. So you should expect, and I say this all the time, you should expect adrenal issues. You should expect sex hormone regulation issues. You should expect changes in your heart rate and your blood pressure. You should expect changes in gut function and physiology, because having sex, sleeping deeply, digesting food is not important if I'm being chased by a proverbial tiger. So all of that stuff gets down regulated. And Mark, what I talk about in my book, I call it the multi-system adaptive disorder, because people want to know, what do I have? Do I have adrenal fatigue? Do I have this? Like, listen, you have excessive cell stress that's being driven by a bunch of these things, and that's causing this excessive load, and all these systems are adapting. So you have a multiple system adaptive disorder. You're not broken. What you're doing is adapting, and we might actually start to see some breakdown, the cardiovascular disease, the disease states, the gallbladder disease. But really what our goal in functional medicine, my opinion, is to be able to be aware and let our patients know you're not broken. You got an uphill battle here, but you're fixable or improvable, but we got to reduce the load to support the shift from allostatic regulation to homeostatic regulation, which is a big deal. And most people think that if I just take these supplements or these medications or this treatment, it should fix me. But if you're in allostatic regulation, you're not using those things the same as you would use them if you were in homeostatic regulation, which is why somebody says, well, I take that, it makes me feel worse. Right. Because your body's using those proteins, those amino acids to do this, not to make sex hormones.
You just perfectly described the CDR stages.
Oh yeah. Well, it's like one of my babies, right? So, but I think one of those things that's really important, you were talking about what's going on from a redox potential. And I guess that's one of the things that I think really important to understand. And I think sometimes the challenge with people taking thyroid hormone replacement maybe inappropriately. I have my hypothesis based on everything I've done is that reduced conversion of T4 to T3 inside the cell isn't broken when there's that cell stress going on, because the endoplasmatic reticulum, the mitochondria, they sense danger. There's all these danger mechanisms. And what they do when they sense danger is they reduce deiodinase 2 activation. They actually increase the ubiquination, increase deiodinase 3 activation, which creates the down regulation of T3 in the cell. They essentially turn off the manufacturing and then pull T3 off cells to turn on some of that cell defense mechanism. So why is that beneficial? Well, if I have reduced T3 in the cell, now I don't have mitochondria going at full tilt, reducing a whole bunch of oxidative stress or free radicals. I don't have enough antioxidant to deal with, right? And so that's my concern for people when they go, well, T4 didn't work, so I'm going to take T3, and it gave me that honeymoon period, but it went away, so I'll take more and take more and take more. And then you get people like I see every day who are on 80, 90, 120 micrograms of T3, and now people are saying, okay, well, now that's not working, so let's take T2 as well. And they're wondering why am I not feeling good? Well, because you're creating potentially so much oxidative stress that you can't manage. That's a big concern. What are your thoughts on that as a person who's kind of talks about this redox model quite a bit?
We need to practice together, my friend. So the analogy I use is it's likened to putting in high octane fuel in a dragster that has no tires. It's just not the right timing for what therapeutic intervention you're introducing into the system. And the cell danger mitochondrial state is the same problem. Trying to over methylate somebody because you've heard from a lecture that everybody that has MTHFR mutations, needs massive amounts of B9 and B12, and it must be good for everybody, right? And then to have them respond untoward, not looking at them as a whole person and asking yourself, where might this person, based on symptoms, be? Because we don't have good ways of assessing where people are in their mitochondrial stages and cell danger response, or where the cell is with thyroid. Why don't people want to look at LDL when they're in the ICU with pneumonia? Well, because it's part of the innate immune response. I didn't know that as a family practitioner. I just knew we didn't do it until they were more stable. I didn't understand that oxidized LDL and LDL went up acutely in the hospital during an MI because of the stress and the perception that the immune system has that there's an attack being waged, or sepsis from pneumonia in the ICU. That's why LDL goes up. Okay, had I known that, I might have had the thought, wait, maybe it isn't just the eggs and the steak you're eating. Maybe your LDL is chronically elevated because of your RA, or your periodontitis, or your Lyme, or your mycotoxin, or whatever is driving the immune system to perceive danger. So this adaptive ideology that you're bringing in is universal, and I think it's a reproducible model that the human body uses at a cell molecular level, all the way up to a macro level at organ and tissue level.
Yeah. And I think the other piece of that is, right, if you have those stressors going on, the chronic oral infection that you're not aware of, that's now releasing PAMPs into the bloodstream, that's activating the immune system, that's triggering a cytokine release, that's telling all the other cells, hey, I'm in a cell danger response, down regulate thyroid physiology.
Yeah.
We then have to keep in mind, oh, is it just elevated cholesterol? Why is cholesterol elevated? Well, if I have decreased T3 inside that cell, I can't transport glucose into there effectively because all the glucose transporters require T3, even the insulin dependent ones. So glucose is going to stay higher. And because I don't have healthy mitochondria, because that's been downregulated, that glucose now is getting transported back out of the mitochondria to make into cholesterol that's going out into the bloodstream to then either get excreted or made into hormones. But to get that cholesterol out of the bloodstream, I need T3 for the LDL and HDL receptors to bind. So without enough T3, I can't get the cholesterol out of the bloodstream. I can't get it into the adrenal gland to make into pregnenolone in the mitochondria. And by the way, I have downregulated T3 possibly in the adrenal gland, so I can't make enough cortisol because I don't have healthy mitochondria. And now that cholesterol is stacking up in the bloodstream and getting oxidized, right? And so all of this stuff ties so much together. But when you take a step back and look at this from a cell perspective, you don't see a whole bunch of different conditions. You say, I got an immune inflammatory process that's going to create a change. And so why does this person have low androgens? Androgens. Well, they got high cholesterol. Well, why do they have high cholesterol? And they have low androgens because they can't get the cholesterol out of the bloodstream into the adrenal gland to make it in there. Okay, well, why do I have that? Well, I've got some type of inflammatory mechanism. So I could give them androgens, or I could look at the bigger picture and say, instead of giving them a statin, an androgen, and aromatase inhibitor, how about we start identifying what's creating that immune inflammatory process and that cell stress response? So not only can they make their own, but even maybe the stuff I need to give them actually works at the receptor.
Yeah. But what you're talking about is revolutionizing the curriculum in every medical school across the country to do that.
That's not going to happen there.
So it's just way easier to give an HMG-CoA reductase inhibitor as a statin to, reduce liver hepatocyte synthesis of LDL than it is to understand cellular physiology at the level you do. And when you understand those reactions and interactions, it all makes sense. I mean, before statins, we think we're so sophisticated with statins in the 70s. What did we use for high cholesterol? We used thyroid. We used thyroid medication for all the reasons that you just mentioned. So those guys knew more about it 40 years ago than we do with our, crazy statins that drop LDL 50, 60, 70%. And now with injectables and biologics and all of these things that are affecting mRNA, and PCK, the inhibitors with LDL receptors in the liver, PCSK9 inhibitors, we're just can't get out of our own way. So when you're thinking about reductionistic medicine and the substitute for understanding the why is trying to own the physiology by blocking a receptor or poisoning an enzyme. And whenever you do that, there's hell to pay. You might get a pretty looking window dressing on a particular analyte on your lab panel, but with every action, there is right? We all learned that in physics. So we've forgotten our basic science. We don't think critically anymore. And so everything we're discussing is seen as yeah, so what? I can spend 5 minutes writing this prescription and I can turn and burn and my fee-for-service model thrives. So this is why doing the right thing and understanding the why is in our model of reimbursement and our perverse incentives the way we do medicine in this country is just so out of step with what you're saying, which is absolutely the right way to look at that.
So I came from that model, right? So when I left, you may have been the same way when you were making that transition, like especially if you have your own crisis, which happens to many people who wind up in functional medicine, is you're angry. Like,
Yeah.
once you start learning this stuff, you're like, why would you not do this? And it's funny because when I wrote my book, The Thyroid Debacle, it had a very, very angry tone in it. And people were saying, man, you're angry. And I was angry. And I was like, man, I got to settle down, because really what I have to realize is these are still good people trying to help people with the knowledge base, the bias, the ignorance that they have. Same here, right? We all have our own biases and ignorances. And so they're not going to change. That model isn't going to change, but that's okay. What we need to do is keep functional medicine, and then build the bridge so that somebody who does practice allopathic medicine, it says, it's not what I do. I'm crisis care. I'm managing numbers. If they want more than that, I'll send them to the functional medicine practitioner. Versus, I had a cardiovascular surgeon, really well-known guy down in Houston, who was like, I heard you on a podcast, but I have no idea what I don't even, it's like a different universe. Like, when he told me that, I was like, what do you mean you never heard of it? But he had never heard of it, but he just heard me talking on a podcast. And here's a guy who's, overweight, pre-diabetic, diabetic, he's on meds, blood pressure, cholesterol, all these things. And he's he's a cardiovascular surgeon, right? This is what he does for a living, right? But he's like, and when we got him off all his meds, back to his high school wrestling weight, and he's like back to normal, I'm like, you can do this in your practice. And he's like, I can't. You don't know the hell that would rain down on me if I tried to push this model. He's like, nobody would refer to me. Like, nobody will refer to me.
And that's the travesty. That is the ultimate tragedy of this story, is that allopathically trained folks like ourselves, who have kind of been blessed enough to be exposed long enough to the right environment, where we say, oh, hell no, that's not all there is to this story. I have given up on being able to feel like I'm going to go and convert those folks, and I don't have enough energy. So I go and teach at IFM in these places where people self-select that are already seen. I can't help everybody, but I can help those that want to be helped. Right. And each of those people have panels of 1,000 or 2,000 people. You can see the logarithmic. So this is the area within education I've chosen to go to meet that inner flame of wanting to share the good news of the gospel of thinking at a cell molecular level, so to speak. So yeah, no, it's interesting, because you actually do become quite philosophical about this approach to medicine after a while. As a new believer, in my analogy here, you're right where you were. There's a test for everything, and I'm very secure in my boundaries, and I know exactly what to do, and I know what's wrong with you, and life seems really quite tidy. And as you get more knowledge and you get exposed to more points of view and you get more clinical experience, it gets really messy. It gets really ugly. And then you have to come to grips with your own ego, what you think you're good at, what you probably are good at, and what you're actually not very good at. And a Mark Twainism comes to mind there, but I won't digress. It's the stuff that you need to worry about that you're darn sure you know, right? He says. But I feel like if we don't come to that point and teach that way, where really what we're teaching people to do is to think critically. We can give them all this information, but at the end of the day, the only hope we really have is to be able to synthesize objective data that we have vetted as good quality, and make best practice decisions based on that evolving knowledge. And it is evolving, and we're perfect at every stage of that. And when I mentor and teach younger practitioners in this space who have the imposter syndrome, I shouldn't be here. I don't know everything. This patient's more knowledgeable than I am. I can't believe I'm getting paid when I don't know what I think I should know. It's this self-imposed perfectionism that stifles growth and self-esteem. And a lot of them go back to urgent care with their tail tucked between their legs because they feel so overwhelmed and out of their element, and just this sense of discomfort. So those of us in this space, I think, have a higher tolerance for not being completely comfortable with what we don't know. But we come, I think, armed with critical thinking and our intellect to deduct and to conclude, using the symptoms that we're gleaning from a good history and pattern recognition to do the best we can with where we are at the time. Ultimately, not hurting somebody in the process. And I think ultimately that's the oath we all have taken. But I love the approach you're taking, where you're seeing things as pathology is truly an adaptive behavior, sometimes of which it's gotten out of control. Hypertension, I believe, is a protective response of the blood vessel, the endothelial lining, to a perceived threat, whether it be torsional stress, hyperglycemia, PAMPs, DAMPs, as you mentioned, issues with infections. And yes, especially with hypertension, there's a large genetic predisposition, of course, but so much of, I think, what we're seeing, and maybe even including cancer cells biology, may have its roots in this maladaptive stress response, where the body is being bombarded with an allostatic load that it is trying to grapple with as best it can without checking itself out.
Yeah. And that, to me, that's one of the downsides to doing too much thyroid medication, because thyroid hormone doesn't just have an impact inside the cell. If there's abnormal cells, thyroid hormone can bind to integrin receptors on the outside of the cell and cause cell replication. And when I saw that in the literature years ago, I was like, well, wait a second. Then is somebody's hypothyroidism more of a protective response so we don't have more abnormal cells? And if that is the case, is there an increased risk of cancer when we put people on thyroid hormone before looking at this from more of a cellular perspective? And I said to my co-author, Dr. Kelly Hallerman, I'm like, here's my thoughts, but nobody will ever do that study.
No.
And then in 2019, somebody did a meta-analysis of people of all the cancers, and found that there is a much greater incidence of a number of different cancers, a bunch of them, in people after getting thyroid medication. And since then, I've seen a number of papers that have said this is an adaptive response to some type of cell stress. Now, nobody knows what to do in that model, but the nice part is we're starting to see it. Yes, too much thyroid hormone into a system that has a bunch of sick cells is probably not a great idea, because too many sick cells is what we call cancer. And so I think we have to have more caution when we're doing it, and not driving TSH down just to drive it down, and not just to treat symptoms, but to take a look what's going on. I do want to get into, because I know one of your things is peptides. We haven't talked about peptides on the podcast. We may not get through all of this in today's discussion. We may have to have another session and bring you back and talk about some of the other stuff. But it's a sexy thing right now. Peptides are all the rage in integrative and functional medicine. I'm not sure how much in allopathic medicine, but it's there. So can you explain to the listeners, what are peptides, and how are they being used to help somebody heal or improve their health who has chronic health issues?
Yeah, I mean, I was late to the party. I was a slow adopter on this, and actually poo-pooed it for lack of a robust literature on it, just as recently as 18 months ago. And as I've done in the past, when I feel that way about a topic, often I get challenged by other providers who are really all about it to go and learn. So I took Dr. William Seed's peptide therapy certification, just finished that about a month ago. And so bottom line, peptides are small amino acid chains that our body has evolved with, that it's used to seeing around. They're cell signaling molecules. Insulin is a peptide. And there's around 7,000 of them that we know about right now. Several of them are FDA approved. Some of them are off-label. But the idea is that these compounding pharmacies and some traditional pharmacies have been able to isolate certain combinations of amino acids, usually under 50 amino acids long, but some are longer, that have specific cell signaling activities, such as weight loss, signaling messages within the body that can help to manage glucose. They have different categories and different crazy names that they go by. There are some that actually help our bodies, our pituitary glands, to make more growth hormone without actually giving growth hormone, and all the benefits that we have there. And we know that after 35, we lose significant amount of growth hormone as we age, just like we do with testosterone and estrogen and all the other hormones as we age. So peptides can be designed to help augment what was once a function that the body took care of naturally. Some of the peptides are more responsive to immune support. I'm thinking of something called thymosin alpha-1. The thymus gland being a large gland that's we're all born with as infants, that atrophies over time, and we become more and more immunocompromised as we age, largely because of that. This is where our T lymphocytes, part of our white blood cells and our immune response, become primed, and it's their college, if you will. That's where they go to be programmed and where they receive their degree, and then they go out to the body and do their work with immune surveillance. So thymosin alpha-1 is an example of something that can actually help bring back some of this innate immune response that we lose as we age. And it's been used with tremendous success in things like long COVID and some other things like that. But you see these things having a modulating effect. In other words, like an adaptogen, a smart bomb, as opposed to traditional pharmaceuticals that haven't evolved within the body, that have been synthesized in a lab. The difference being that peptides, being a natural product that the body is aware of, that recognizes it, you have far fewer side effects. And it's because of this being extracted from your body versus made in a lab. Statin, for example, new to nature molecules. And you can see the difference in the side effect profiles in those pharmaceuticals that try to own your physiology by blocking a receptor or poisoning an enzyme. Whereas peptides appear to work with your body's physiology, whether it be supporting nitric oxide, whether it be supporting the redox status in the cell and in the mitochondria, directly with the electron transport chain, and using these NAD and NADPH molecules that are part of the alphabet of what keeps us having a reduced and oxidized state, which we're always in a state of balance and within the cell, alive. Some of these peptides are balancing glucose and insulin cell metabolism, neurotransmitters, so serotonergic neurons and dopaminergic neurons. And so they're used for things like anxiety and cognitive decline and immunocompromise, folks that are having trouble getting rid of Lyme or chronic illnesses, COVID. We're using these things for hair loss. We're using these things for weight loss. There's a number of them that are being used for sexual dysfunction. And so that's kind of the most recent thing I've added to my clinical armamentarium. And I've just had tremendous success with people with very few side effects coming to me, doing their lifestyle work, their caloric restriction and their regular exercise, getting results that they never got doing those things alone. So it's exciting. It's exciting.
So these are all products that we make endogenously. For the listener, that means these are things we make normally. And when we're saying that as somebody goes through life, they have reduced androgen production, or they have reduced estrogen production, or they have reduced peptide production, or reduced whatever, right? I think that's the challenging part. Is it because we're getting older that these things are reducing? Because if it's just because we get older, then my argument would be, if this is the way we're designed, then why are we trying to put all the stuff back that the body has been designed to down regulate? Like, we're not, women aren't having babies into their 70s. So why are we giving them the estrogen of a 25-year-old, right? Or are we reducing these things as we get older because we're fighting this battle of chronic inflammation and oxidative stress for a longer period of time? So it's really a time thing, not an age thing. And what happens, and this is kind of my take on it, but I want to get your feedback on it, is that because we have this excessive load that's creating us to operate in this allostatic regulatory mechanism, and we're turning down peptide production, so we're not bringing the amino acids in, and we're not building those amino acids into these peptides. And why would the cell not want to do that? For the listener, if there's a threat inside the cell, it's thought that, why would we make more peptides for that threat to use? If it's an organism, that it could be like, oh, great, now I got these building blocks that can help me too. So it's not that we downregulate this production. If that's really more the mechanism, and we get stuck in that allostatic regulatory process for an extended period of time, the benefit here of these peptides is sometimes we get stuck in this operating mode. The thing that got us there to begin with is gone. But because we have such a stress load on the physiology, we're kind of stuck in this operating mode. And therefore, it's hard to heal. It's almost impossible to heal and repair if we're stuck in that mode. And if we can give some of these peptides, that may help the process of rebuild and regeneration and help that restorative function. Is that fair?
It's fair. It's absolutely fair. In the context of aging alone, there are things that the pragmatist in me says, we know that we live in a toxic rock, a toxic soup of problems that we're getting in our food, water, and our air, and our relationships. And at the end of the day, it's probably promoting cellular senescence. And really the peptides that I'm referring to, in particular those that support growth hormone, are really battling and beating back the process of cellular senescence, really trying to get at a cellular redox level a state of homeostasis back, so that those cells don't succumb to this senescence phenotype that we call these SASP cells, they're called, where they're secretory senescent cells that no longer divide, but they don't die either. So it's a very peculiar process that our cells go into when they jump out of the cell cycle and go into this. And then they promote other stem cells, pluripotential cells, to become just like them, more zombie cells that won't die and yet are just bad influence and bad actors, spewing inflammation and toxicity everywhere. So as long as we're exposed to all of these environmental things that are leading to this aging process, and we have cells that are becoming less and less functional, making the tissues and the organs that create these molecules, these macromolecules, such as cholesterol and steroids and hormones, I think it's a humbling task to think how else can we get back to health? It's I don't know of anybody who can put themselves in a bubble and avoid the allostatic stressors of environment and the epigenetic outcomes of living here without introducing something like this that is natural to help us hit a reset. And that's why peptides are used as a bridge. And if people are using them as an annuity for a long-term treatment strategy, as opposed to getting to the root cause, that's a mistake. And again, that's allopathic reductionistic thinking, putting a Band-Aid on something and so the symptoms go away. So that's the beauty of these things. Most of these peptides are only used for 12 weeks at a time. Sometimes you'll have to take a break and pulse them. And it's really allowing the cell senescence to turn the hands of time back at a cell molecular level while you're introducing a better diet, a less toxic water source, reducing the emotional stress and how the maladaption that it comes from not knowing how to deal with psychological stressors. So our realities are those. We have bandages we call pharmaceuticals, which chase symptoms like whack-a-mole. And then we have peptides, which I believe are going to revolutionize medicine because it's working at reestablishing cellular redox, reestablishing a homeostatic regulatory pattern, as you call it, within the context of an aging frame. And, you can argue what is the cause of aging. There's certainly biological clocks and genetic and epigenetic forces at work. But for those things that we do have control of, which is premature aging of our immune cells, redox status of all of our cells, and if we can find that peptides can reestablish these physiologic points and hit a reset, man, bringing that alongside therapeutic lifestyle change is a powerful duo.
But this is I guess the challenge becomes, this looks like this easy strategy that, hey, I don't have to change anything. I'm just going to take a bunch of peptides and this is it, right?
That's just the point. If, let me give you the GLP-1 agonists, semaglutide, Ozempic, for an example. We got all the fad going on. Every endocrinologist is writing this stuff. And they're not giving any dietary modifications to their patients necessarily. They're certainly not talking to them about chemical and toxic burdens, which are obesogens. Right. They're not necessarily talking to them about their gut microbiome and how having a dysbiotic microflora can lead to obesity or insulin dysregulation.
Or loss of the GLP-1 signaling to begin with, right?
The incretin signaling in the first place. They're not talking to them about the fact that you have all of these receptors and not just the GLP-1 receptors, but others similar in the brain, the heart, the lung, the kidney, outside of the GI tract, and all the pleiotropic effects that these things have. And so we know that the study, for example, on semaglutide showed with 15% to 50% body weight loss, these were in people that were doing strength training 4 and 5 days a week and had caloric restriction. So without the combination of good therapeutic lifestyle changes, and that's what our clinic is about. We're taking these folks that are just doing the drive-by TRT clinics or the NAD infusions down the street and making a bunch of money. And we're saying, okay, well, we do all those things, but let's look at the rest of you as a holism. What is going on with your lifestyle? How are you? So we have to say that you're going to just take a shot. And this is what we're seeing. A lot of those people who have seen those other specialists who aren't holistically trained, who are just writing the prescription, as soon as they get off of the tirzepatide or the Mounjaro or their Ozempic, their semaglutide, after 3 to 6 months, they have a rebound weight gain. And then they say it doesn't work, or it causes muscle loss, even worse with this latest thing. The reality of it is they didn't do the other things that you needed to do to have sustainable weight loss. So it's not that the drug didn't work, or the peptide didn't work. It's that you used it inappropriately. If you didn't take in enough protein while you were on your GLP-1 agonist, you didn't have muscle maintenance. The drug didn't cause a loss of lean muscle. Your anorexia, lack of appetite from the drug, and lack of dietary counsel and being proactive, getting you on enough macros and the right ratios, is why you lost lean muscle on your BIA, your percent body fat, and looking at fat-free mass. So there's a lot of misinformation, I think, specifically on GLP-1s right now, based on people just not understanding how the studies initially were done, what else was done with lifestyle. So yeah, to just give these things as an injection or a prescription, that's not at all what we do. And it's wonderful because I think we're the only clinic up here in the Treasure Valley and Boise area that's actually looking at using peptides within the framework of holistic medicine.
Yeah. And so for the listener, I think the key piece from that is these are a tool, but not
Right.
the tool. And
Right.
so if you're interested in peptides, we're not going to give it justice today, but these are things that people in this space are potentially using to help with that healing process. But if you don't do all the foundational things well, you're probably going to have some limited success. But if you're going to a clinic where that's it, like come in, get your peptides out the door, this is easy, you're probably going to be underwhelmed in time, and you'll have probably spent a good bit of money and not really achieved what you were hoping to achieve. Is that fair?
Absolutely. The IV infusions of NAD and the half-life, and not understanding the salvage pathway of NMT and NAD and CD38 and how all this works at the cell level. These clinics aren't paying any homage to the physiology. It's an injustice. It's just greed. The TRT clinics, which aren't talking about insulin resistance or what's going on with the thyroid, who are just indiscriminately pushing guys up above 1,500 on their total testosterone. Oh yeah, they feel better. But again, for every reaction, there's an equal and opposite. This is an arrogance that needs to end. So those of us that are trying to do responsible medicine, I think in the era of a lot of really sick people who have got a handful of prescription drugs, who are trying to move the needle, who are trying to get buy-in, it's exciting to be able to use something with such a low side effect profile like peptides, appropriately dosed hormones in the context of addressing diet, sleep, exercise. What other toxicities are going on? Statins, they're not all bad. I use them in certain high-risk patients, knowing that they're toxic to the mitochondria, knowing that it's going to dysregulate insulin and raise their sugar. And in some people, it still makes the most sense. It's the best tool I have in all practical application to keep people out of harm's way. So
to be fair,
really,
it's a really
point that you make.
Yeah, and to be fair, there's a lot of people that don't want to put any work into their health. So we need some of these things to keep them managed, to keep them alive, to kind of Sherpa them through life, right? But we also need to make sure that we give people the opportunity and say, hey, we can do this. This is the easy, fast thing to do. There's consequences, there's a cost, and more than just financial. And there'll be more of these things. But if you want to get to some of the root issues and address issues that create this stuff, man, there's a whole nother process over here. And unfortunately in today's world, it's not covered often in an insurance-based model. And so it often winds up being at an out-of-pocket expense. But I tell patients, when they ask me about insurance, well, insurance covers this. Okay, so you're seeing these people for the last 10 or 15 years, and why are you going to see them if you're not getting better? Well, my insurance covers it. Okay, so you're still paying for it. you're paying in your premium, you're paying in your office visit. If you had to pay that same practitioner for the advice and the visits, if you had to pay their true visit fee out of pocket, would you still go see them? No. Why? Well, why wouldn't you still go see them? Because I'm not getting better. Well, then why would you still see them in that model? And then you're still spending money. It'd be better to spend that money maybe directly out of pocket to get somebody who's going to get you what you want. If you really do want health focused care, sounds mean, but that's not really what allopathic medicine is really all. That's not their jam. That's not their best thing. Crisis care, acute care, they're the best in the world, right? But healthcare and recovery of optimal physiology, not necessarily the strongest model there. But that's why we're here. That's why we have to build that bridge to say, hey, look, that's what you do. That's great. If they want something different, come see me. If they're frustrated, you're frustrated, send it to me. That's what I do. And I see more, it's crazy, but I have more clinicians sitting in on my functional medicine visits so that they can learn what's going on. Like, why are you saying that they need to reduce their thyroid dose? Okay, let me explain it to you. See this? Here's what this shows me. Here's a free T3, free T4 ratio. This is what it tells us. Now, we just looked at the thyroid panel. What you didn't run was any inflammatory markers. So look, here's my panel. Here's all the inflammatory markers. This is why that's going on. And the reason I know there's this tissue hypothyroid state going on is because, look, I got glucose resistance. Look, I've got elevated lipids. Look, I've got reduced renal function. Look, I go through all my hypothyroid tissue patterns in all the different systems. And they're like, okay, what do you want me to do? But there's a need to learn because they're frustrated. And that's what I tell a lot of patients. When you come to functional medicine, don't necessarily fire your MD. We need that MD, and we need somebody that you like and resonate with and who's willing to work with you. But understand that they're not doing the same thing we're doing. They're not focused on the same, they don't have the same knowledge base. And we know you're probably their worst patient and they want help too. So use the honey, explain to them what's going on. Let's build a bridge to your MD, not have this, oh, he said this and you said that, but say, hey, look, this model's not working for me. I understand what you're doing. I know you're trying to do the best for me. I'm trying this other model. It seems to be working. Here's the recommendations. And can you help me make some of those medication doses? Because I don't prescribe. You have the liberty to be able to prescribe and change those things. I don't. But then what I'm seeing is maybe that first time the allopathic physician is a little like, but then once they start to see the changes in their clients, I get no pushback. It's like, hey, whatever he wants, whatever he needs, like, sure, we'll do it. Because we're not doing those things blindly. Like we're making a change. We're retesting panels. We're looking to make sure it's the appropriate change. If it's inappropriate, we go back. If it's the right thing, great. Here's what we're going to do. Kind of hang with this. And then when we're ready for a dose change, we're going to go send you back and get that done. And I think that's really what we need to do. Instead of being the angry functional medicine practitioner, we have to really do a great job building the bridge.
I'm a big believer in that. When we have our younger providers come in, I say, look, it's a parallel model where they're here and we're here. It's not this, and nobody has to diss on each other. Operate out of an abundance philosophy. You're going to bring more positive energy and hopefully add to the experience, whether it be a good one or bad one from what they've had. And I've always been a believer that if you're good at what you do, you don't need to talk negative about anybody. Your work is going to speak for itself. I always like to think of, as far as hormones, the importance is a spectrum, right? The more receptors a hormone has, and the more diffuse and the more tissues that have receptors for that particular hormone, the more important it appears to be. And thyroid, I think, maybe secondary to only just vitamin D, probably has some of the most receptors of anything, and then maybe testosterone after that. But I like what you're saying when you talk about functional levels of dysfunction, meaning cellular level hypothyroidism versus following analytes, labs, as somehow being the holy grail.
End all be all. Yeah. And we already know that those values don't necessarily tell us what's going on in the cell and tissue. That's one of our biggest challenges. We don't have great indicators of what's going on in the cell and tissue. Mark, listen, it was a great discussion. We didn't get through probably half of what we could have talked about, but I appreciate you coming on. You're more than welcome back anytime. Maybe next time we talk in depth about hormones and bioidentical hormones, so we can have a discussion about that, because there's pros and cons to that too. But tell everybody a little bit, like, if they want to hear more about it. You said you have a podcast, you have a clinic, so give the listeners a little bit of where they can hear more about you.
Yeah, so we're in Eagle, Idaho, just about 6 miles outside of Boise. We've got 3 locations in Meridian, Boise, and in Eagle. 2 of the locations are an insurance-based functional medicine. We've got the bulk of our providers, probably 17 of them there. Pediatrics, adult, and women's health. I work in the Eagle Clinic, which is exclusively a cash-based practice. It's called Functional Medicine of Idaho Center for Optimal Health. And yeah, if you Google that, you'll find us on the website. But optimal health is really based on, we've got a couple of regenerative providers in there. We've got a couple of us that are more knowledgeable in peptides and hormones. And what we're trying to do is bring these bigger ideas together with patient symptoms that are, we tend to get the toughest of the tough folks that come from the other practice, but we're also getting a lot of patients that just want healthy metabolic weight loss, and they want optimization of their hormones, meaning within the context of their toxic load, their allostatic load, their lifestyle, their diet. We are assessing their hormone levels, their function, and we're trying to get out of just looking at reference ranges and practicing reference range medicine. I don't know about you guys, but if you look at how reference ranges are set, and then you go walk through Walmart, that's normal, guys, and that's not healthy anymore. And so that's what optimal health is really all about, is taking people beyond just the status quo and what they're getting from allopathic out here. So no, I appreciate the time and to be able to share with everybody, and hopefully it's been helpful to somebody.
Awesome. All right, everybody. You may have to listen to this one a couple times, share it with friends and family. And of course, as always, if you like what you hear, go rate us on iTunes or wherever you get your podcast. I think 5 is the one that you want. But Mark, again, thanks a lot for coming on the podcast. It was a great discussion. And we'll try and do this again sometime in the future.
My pleasure. Thank you.